How big an effect do you think endometriosis has on the average person who has it on their daily life?
It has a huge impact. I think people probably fall out of relationships because they have pain with sex and they can't have sex. And so then they're like, okay, well, that guy's not going to work out for me because I can't really meet his needs and I'm in all this freaking pain. One of the main questions I ask people is about can you go to work? Can you go to school? Can you go out with your friends? Can you do anything fun? No, I have to move my entire life around. I have to plan my vacations. They have to choose different jobs, right? This disease requires the most attention in your life right now, and you need the most support from an employment standpoint, from friend standpoint, from relationship standpoint. So it's so far impacting. And again, they just have also all this trauma too.
So, Jill, I feel that endometriosis has had a lot more awareness in recent years. There's still probably a long way to go, but for someone listening and who's maybe heard the word endometriosis, what does it actually mean in terms of physiologically what is happening inside a person's body?
Endometriosis is a condition where tissue similar to what you bleed every month has found a residence or a home in other parts of your body. So we've got this ectopic or this tissue that's misplaced. And when that tissue finds a home in another place, it's also very hormonally responsive. So it's additionally making its own hormones as well. And it can cause a wide variety of symptoms. And it can also cause infertility. It can destroy vital organs. But essentially, it's tissue where it shouldn't be.
It's often referred to as a gynecological condition, but I guess that's a bit of a misnomer because, it's part inflammatory. It may be in part autoimmune. There's likely a genetic component. And as we're beginning to understand, possibly even, some microbiome dysbiosis or disruption may be contributing. Is there an environmental, impact on it as well? So given that there are so many different factors which could influence the disease process of endometriosis, the two questions that really spring to mind. Why haven't we come up with a cause, or at least a sort of a constellation of causes? And how close are we to getting there?
So I actually just got back from an endometriosis conference over the weekend, and we all have the same questions that you're asking as well. I think that there is some new research coming out by one group, and I think it's going to take time. In the last few years, we've really brought awareness to it, but the research is just not there. And then also the people that are doing the research, they're doing the same kind of research. So we don't have any new thought leaders. We don't have any new researchers out there saying, hey, let's look at this a different way. And so at the conference, actually, there was two gals who presented, and they were talking about looking at the research in a different way. And one of them actually stood up, the physician who was there, she stood up and she said, I really think that this is not going to be a surgical disease in the future. I think that we'll eventually find what the causes are, and that it won't be something we need to go crazy and cut out. It'll be a targeted therapy that can be given without needing to go kind of at the end of the disease and do all these crazy measures to cut it out. What was your second question?
How close do you think we are to actually coming to terms with what's causing this?
I think I'll be dead.
Not in your lifetime. You don't think we'll find out? Wow.
I mean, I'm 45, right? So, and I have a lot of really bad habits, so that, could be playing into it. But I think, I mean, if I had to be optimistic, I would say probably in the next 25 years, we'll be closer. But I think, like I said, there's only really, it sounds like one or two real thought leaders in the area that's doing different research, meaning research that we haven't been doing for the last 20 years with the same people getting the same funds to do the research. So
Yeah.
we need we need fresh new thought leaders, and the money needs to go there. So in order to make a big difference, in my opinion, it sounds like we need new people doing the work.
On the topic of funding and research and new perspectives, it looks like in 2022, the National Institute of Health allocated, I think it was 16 million US dollars towards endometriosis. And, assuming a rough incidence in the population in the US of endometriosis of around 11%, that actually works out to around $2 per woman per year, which is significantly less than most other conditions. So just on the basis of that, there's clearly not enough input to get the output we desire.
Yeah. I mean, that's the problem. I mean, I think in the last 10 years, in my opinion, that we've built a lot of awareness around the disease, and now the people who have the money to allocate to the researchers are like, "Oh, okay. We can now take this money and put it in the hands of the right people," but that hasn't been done. That doesn't surprise me. That number, $2, that doesn't surprise me at all, but I think, it's been a few years since that. I think you said 2021. So, I mean, it's been 4 years, and I do think there's been some movement in the last 4 years that there's more awareness, there's more people showing up for legislation and more people, trying to advocate for the disease. So, again, that's another barrier, right? That's gonna take time, and they've got some more funding happening even in the last year, but that's why I say 25 years, because we've just basically built awareness. Now we need the new people to get the money.
You mentioned before, about endometriosis is the presence of these cells similar to that found in the lining of the uterus, which can migrate or be found in different parts of the body, and they can form lesions, plaques, and sort of plaster themselves everywhere. Now, I guess we've sort of touched on the point that we don't really know why this happens, but when you have so obviously, for anyone who has a basic grasp of human biology, the cells lining the womb, they are quite sensitive to changes in hormones and other chemicals. They bleed. So naturally, these similar looking cells who are also misplaced all over the body also bleed and
Mhm,
also cause chaos wherever they are. So
mhm,
if there is endometriosis, like tissue in other parts of the body, so for example, in the intestines or in the ovary, they can actually cause bleeding at certain times of the cycle on the bowel, for example, or on the ovary or on the bladder, which can then cause symptoms. What is the sort of average incidence like globally for endometriosis? And is there a huge kind of sleeping population of people
mm.
suffering that we're really not getting to the bottom of, do you think?
Yes, I think there's, quite a few. Um, the kind of the classic number is 1 in 10, and you'll see all that hashtag 1 in 10.
Mm, yeah.
I think someone else had pointed out that it's probably closer to 1 in 7, and I think that's a more accurate estimate, 1 in 7. There like, even yesterday, I was doing surgery with someone, and we were doing the surgery. It's not my patient, but another patient, and we were doing this surgery on this very, very, very large uterus, and, that was kinda thought to be the reason for this gal's symptoms. But there was stage 4 endo in there too. And in kind of talking with the surgeon, he said, "Well, she doesn't really have any pain. It's really just these heavy periods from this huge uterus, this huge fibroid." And so it's interesting. Like this patient isn't even thought to have endometriosis. She doesn't really have pelvic pain. I mean, she has painful periods, but there's just so many out there. And again, the population out there that has unexplained infertility, like there's so many of them that actually have endometriosis, and it could be a very minor stage of the endometriosis, but a lot of them just have this blanket unexplained infertility, and they might have one ditzel of endometriosis, but they end up in the REI, or the reproductive endocrinology and infertility specialty office, undergoing IVF. So it's wide reaching. I mean, even like I have a part-time nanny, and she, was telling me the other day she couldn't come because of some health thing. And as I come to talk to her, I'm like, "You have endometriosis."
Wow.
And I kind of joke that like my kids, they tell me something like I have a headache, and I'm like, "Well, you probably have endometriosis in your brain." So a lot of people have it. In fact, one of my jobs, or one of the ways I see it, is when people come in to see me for pelvic pain, you need to convince me that you don't have endometriosis.
Wow. That's a novel and refreshing way to actually put it, because a lot of people I've seen on the internet, certainly, and a lot of people who communicate with me are actually begging their doctor to take them seriously. But actually, it's really refreshing to see that approach where actually you're trying to exclude that first.
Yeah. That's like my number one. You come in, you need to convince me that this is not endometriosis. So I think for me, I assist on a lot of surgeries. I do a lot of my own surgeries, and even just simple things like people having tubal ligations, removing the fallopian
Mm.
tubes. Like I'm helping them, I'm assisting them, and I'm like, there's endo over there.
Wow.
And I sound like a crazy person in the OR, but because I think everything is endo. But I see it so much. In fact, I don't know if like a lot of times I was talking with my colleagues yesterday, and she's like, "Do you ever like not think something is endometriosis, or do you ever not see it?" I'm like, at this point, I'm honestly starting to wonder. I really am honestly looking around in people's pelvises with people, and I'm just like, it's there, it's there, it's there, it's there.
You know, endometriosis is technically a benign condition, meaning it's not cancerous, but some of the terminology associated with it, progressing from stage 1 to stage 4, the fact that you can find endometriosis so far beyond its sort of origin site from the uterus, it can be spread like a cancer to other parts of the body, how aggressive it is, how much of a negative, deleterious impact it can have on people's lives, almost makes it sound like a cancer in the way it
Mhm.
spreads and it invades organs, and how common it is as well. We know that cancer is present in 1 in 2 people in their lifetimes might develop a cancer. And not saying endometriosis is 1 in 2, but there's a lot of parallels between how it almost behaves invasively and quite insidiously like a cancer. I mean, you can have chronic symptoms for so long and overlapping symptoms with other things. Tell me a little bit more about those stages. You mentioned there about stage 4, which presumably is the most severe end stage where it's, really widespread and pretty bad. Talk me through the different stages and how they progress, and if it necessarily needs to progress in every single person.
Sure. So stage one is going to be that, and it's all an anatomical thing, right? So the stages are just for anatomical purposes. It doesn't tell us a lick about your symptoms. So the stage one, you're going to see very minor endometriosis, limited to the pelvis, lesions that are small, kind of surface level. They're not diving themselves deep into the tissues. Those are usually very easily resected, and you can find one and they can cause quite a bit of symptoms. Stage two is just a progression of that. The lesions are a little bit more widespread in the pelvis, a little bit farther extending. And then stage three, again, kind of say 3, 4, I kind of see as a bucket, right? 1, 2 is kind of its own bird. And then 3, 4 is kind of another kind of bucket. And so in 3, 4 disease, we've got larger lesions, more of them. And now they're really starting to do kind of crazy stuff like the cancers can do. And having done a residency in OBGYN and knowing and doing all these ovarian cancer surgeries, I'm telling you, it's the same thing. It's the same thing. From a disease progression, now, ovarian cancer is much more aggressive, but not some of those stage 4 gals, they have
Mm.
you it looks like sometimes ovarian cancer, and the way it invades the tissues in the bowels and connects and puts things together, it's a very similar thing. So, I often refer to it as like a benign cancer, but once you get to those stage 4 disease processes, the challenge in there in surgery is basically you need to be like an oncologist. You need to be able to if you can cut out, really severe ovarian cancer, that's basically what you're doing when you're cutting out stage 4 endometriosis. So it's just kind of an incremental anatomical destruction. It's, starts very small. And then once you get to stage 4, we're talking about things stuck together, things invading, and just really widespread disease.
So someone with stage 1 could have far more severe symptoms than someone with stage 4, but given the anatomical progression and number and size of stage 1 through to stage 4, it's probably, we could say, more likely that someone with stage 4 is more likely to have more symptoms because of the impact of the different organs, or is that not always true?
It's not always true, but I do think that, and that's what we've said for a long time, right? People with stage 4 don't have severe symptoms, and they have stage 1, have one tiny ditzel like on a ligament, and
Mm.
they can't function. But I actually think we've said that for a long time, but I actually think the underlying there may be a role here for the pelvic floor. So I know we've said that for a long time, but we don't also screen for all the other conditions that could cause pelvic pain. And I think the biggest thing there is the pelvic floor, right? So when I have someone with stage 1 disease and I totally cut it out and they have severe pelvic floor muscle dysfunction, their muscles are tight and tense and they have a history of trauma and they have this stressful job and they're sitting all day, on their computer, and they bike, they're a cyclist or they run, and they have this one ditzel of endometriosis and we cut it out and they're still in severe pain. I'm like, it's your pelvic floor, and they'll go and they'll rehabilitate with pelvic floor PT and they'll be really empowered because they're like, well, I know I have this endometriosis and maybe that inflammatory response is also contributing to these tense, tight, contracted pelvic floor muscles. But really where they see the relief is when they go to pelvic floor PT. And so I feel like we've always said this about stage 1 through stage 4 and this discrepancy between the symptoms. But I think if you look at the pelvic floor, maybe we're not screening for those women who probably have more severe pelvic floor muscle dysfunction than we may have in the past. And that would be an interesting study to kind of see, is the reason why the symptoms don't correlate because people don't even know what the pelvic floor is,
Do you think that's a problem inherent within medicine where we're so focused and fixated on, the actual cause and the thing that we can see in front of us and bringing the cart before the horse where we say, we've seen the endometriosis, that's causing all of these symptoms, but actually those sort of lifestyle modifications and the sort of hidden things like maybe training your pelvic floor every day or retraining your pelvic floor so it does what it's supposed to do when it's supposed to do, that sort of disappears and goes on the back burner.
Mm-hmm.
And actually we're not focusing, we're so fixated on erasing the problem or what we think the problem is that we don't focus on symptomatic relief, which actually may sort the thing out in the first place. Like, often, over the years, I've seen patients with obstructive defecation, severe constipation, pelvic floor problems, or inflammatory bowel disease. A lot of those things cannot be cured with 1 or 2 clinic visits or even surgery in some cases. But if you offer dietary, lifestyle, and pelvic floor support, the symptoms sometimes go away to such a degree that they basically don't have the condition.
I would agree. And that's why, I have a very long wait time for surgery, but it actually is an opportunity, to be completely honest, because I'm like, listen, I can get you in 4 to 6 months. Okay. But in that meantime, like we have to focus on everything outside of the operating room. And do I have people canceling their surgery once I get to that 6-month mark? Yes.
Wow.
They'll be like, I'm okay. I don't think I need surgery at this point, or I can't have surgery. Like I'm doing well enough where, I got to live my life. I can't recover. I have 3 kids or I'm a teacher. Like I got to go back to school. So I do have those opportunities. And I think that, we have this group of people, right? We have these doctors and they want to be doctors and specifically surgeons, right? They want to fix stuff. Like that's who we pick. Okay. These are the fixers, and myself included. Like I want to fix your problem as quickly as possible. Let me use my technical surgical skills to fix you.
That's what surgeons are.
Yeah. So, and again, I think patients also want that too, because they're like, I don't have time to go to pelvic floor PT every week. I'm not changing my diet. I don't want to take these supplements. Like I don't want to drink water. Like I just need you to schedule me for surgery and cut this out. And that's actually one of the biggest problems I have in seeing patients for chronic pelvic pain is like trying to get them out of this like fix it mentality.
I'd love to, shortly, I would love to sort of dive more into that sort of lifestyle modification. But just quickly wanted to touch on the fact that I think you briefly touched on it there about how endometriosis can impact other organs, for example, in the thorax, in the sort of chest, the diaphragm. What is the full extent of where these endometriosis plaques and lesions can extend to? Because obviously a lot of people probably are increasingly aware that they can go to the bladder, the bowels, the ovaries, the side wall or the floor of the pelvis, and maybe even the nerves in the pelvis, which contributes to leg pain and back pain and all these other weird and horrible things. But also there's an understanding in a small group of people, or even smaller group of people, that it can affect the lungs and diaphragm and cause people to have, chronic coughs or even cough up blood as a rare symptom. Where else could it go?
It's very far reaching. The more I kind of dive into it, I mean, they found it in the brain, they found it in the eyes. I think
Wow.
there's I don't know that there's a limit to this disease. It really can go anywhere. I think for the vast majority, though, it doesn't. I do think there's like this subset, maybe 10%, who have this very extensive disease in varying places throughout the body. But I think for the vast majority, I don't know, that could be a biased opinion, but I think it kind of does limit itself to the abdominal pelvic cavity.
Yeah.
And then there's like this group, this separate group where it's all extra pelvic and it's like all over the place. And I was gonna say, I heard a really interesting presentation over the weekend about neuropelviology and kind of the impact that the nerves have on endometriosis. And there's people like literally looking at just releasing these nerves in various places in the pelvis and just the relief that they get. So basically, the disease can grow and strangle these nerves. And these surgeons are looking at like very specific nerve responses and how just kind of dissecting and releasing those nerves can help with all of those leg and maybe back symptoms. Is very interesting, and I'm not doing it, and I would like to be able to do it in the future. But again, kind of back to your question, I don't think there's a limit. These people, I mean, the disease just does what it wants and goes what it wants. Very similar to cancer.
I mean, I had a friend of mine who she's in her mid 20s and she went for years without an endometriosis diagnosis. And she was eventually diagnosed with thoracic endometriosis. And she never had any pelvic symptoms. And she was all of these extra pelvic symptoms, as you described, where she would get short of breath. She would have, recurrent pneumothoraces, parts of her lung would actually collapse. She was coughing up blood, feeling fatigued, and having iron deficiency anemia despite not having heavy periods. And it was only after being shuttled around for, I think, 5 or 6 years or even more, she then got certain scans and then referred to a specialist hospital, which actually has a center for thoracic endometriosis. And then they investigated it and found she had this sort of rarer subset of the condition. I say rarer subset, but I think more people are being diagnosed with thoracic endometriosis now because of this broadened understanding that the symptoms are not just women's health symptoms, right? And I think
Yeah.
that's maybe where medicine shoots itself in the foot, where we classify it as a gynecological condition. So then you already limit your field of vision to, oh, it's got to be vaginal discharge, changes in the period, pelvic problems, abdominal
Yeah.
pain. And then you don't think about urinary problems, bowel problems, chest symptoms, back pain, leg pain, because you don't associate that classically with a woman's health problem or a gynecological problem, right?
Right. So that's the thing. We need a really all medical specialties, especially the surgical community, needs to be educated in this disease process because you don't know where the patient's going to go first. And so they end up like your friend, right? Shuttled for years. But I mean, cardiothoracic surgeons need to know about this, right? General surgeons. And I mean, it needs a very broad development in the medical community to say, hey, don't forget about this on your differential of diagnosis when somebody walks in to see you. But I do think that's like I think that that's a separate group that we need to study is these people who have like your friend, no pelvic symptoms. Like I think that's kind of a almost like a variety of endometriosis where we really need to dive in and look at these people and how did they get the disease, where they have it. So I think we need to spend some time really focusing on that group. And I would say it's not the vast majority, but that specific group of patients is I mean, they really struggle when it gets to that diaphragmatic disease or that cardiothoracic disease. That's a real struggle and I feel for
Scary
those
stuff,
people.
yeah.
Yeah, I really do.
Now, I've had a lot of, interactions with people with endometriosis almost by accident in my own sort of career because, in general surgery, typically I'll see a lot of women, young women with pelvic pain and abdominal pain. And often they would get referred to the general surgery team as suspected appendicitis or
Mm.
some other bowel problem, inflammatory bowel disease, flare up, or something like that. And, the general surgeons would often do blood tests, often very normal. They would do an ultrasound scan, not very invasive, no radiation, also normal. Sometimes, with really bad pain, they might get themselves a CT scan. And often those are also normal. The patient is discharged, having been told that everything is fine, everything is normal, none of the tests picked up any positive findings whatsoever. Maybe at most some physiological amount of blood in the pelvis, in the pouch of Douglas, and then they're discharged. And you often see this happen time and time again, where you see that subset of patients, young women, be discharged with normal scans and normal blood results, and they come back in maybe a few days later, maybe the next day, maybe the same day, or a few weeks, same problem, same scans and blood tests, normal, discharge, and they come back. And it's only that cycle is broken when someone decides to say, hang on, this person's now come back for the second, third, fourth time. Let's put a camera inside their abdomen. Let's laparoscope them and have a look inside to see if it is appendicitis or something else. And surprise, surprise, you go inside, and often it is something like, I don't know, a ruptured ovarian cyst, endometriosis, or some other chronic gynecological issue. But more often than not, I have seen that with endometriosis, where, someone is either underdiagnosed or misdiagnosed.
Mhm.
And eventually it takes a few goes for them to actually face the reality that, the reason why everything was normal was because they had endometriosis, which isn't often picked up necessarily on these sort of simple scans that we do. Do you see that often, and a lot of your referrals coming your way in that sort of vague?
Yes, I've seen people ping pong throughout our medical system, and I work in a large integrative health system, so people get ping ponged around for a year or 2, and then they're like, "I don't know, just go see her and see what she can come up with." My favorite is, like, when they've had, like, everything removed, their uterus and their ovaries and all the things, and maybe they didn't even see endometriosis or they couldn't recognize it, and then I'm like, "Whoa, did anybody like, on that photo, I see endometriosis. Did anybody bring that up?" I that is a real struggle. I that's why I think, like, we need to have a very there needs to be education within the general surgery community, all the different surgical subspecialties, anyone that may have contact with this disease. Hey, don't forget about this. This needs to be on your differential. And I don't think, even general surgeons, like, they don't even spend that much time. I mean, if you ask them what it is, I mean, I can ask a general surgeon next time I see them in the OR. I don't even know if they could explain it.
Probably not.
Yeah, so it's crazy. And same thing, like patients will say, I had a cholecystectomy or I had my appendix removed. I'm like, okay, well, what did they see? And they're like, I mean, did they see any endo? And then they'll go back and they'll ask their general surgeon if they saw endo because they didn't document or anything. And they'll be like, well, what's endo? I mean, it's nuts.
Well, to be honest, in the early part of my surgical career, I didn't know what to look for with regards to endometriosis. And I'd also classify myself as someone who couldn't fully understand what endometriosis was. It was only when I found this weird, dark, chocolate-colored lesion on an ovary, and I was looking at the appendix, which looked normal, I called for the gynecologist to come in and scrub in and, take over, essentially. And they were like, oh, that's probably endometriosis. And I was like, oh, interesting. And over the years, I came across more patients with endometriosis, either incidentally or we discussed them as part of another case. And I then just started going into a gynecology surgery list just to, I got permission and sort of had a look inside just so I could see some of these
Mhm.
endometriosis cases. And then later on, towards sort of the middle and towards, the later stages of, doing surgery, I actually was involved with joint cases with gynecologists doing endometriosis shaves on, the rectum and trying to get rid of, those sort of real horrible lesions which make bowels stick together. And it took me a long time to educate myself through personal education, but also seeing these patients insides to understand what endometriosis look like. So I agree there's a huge backlog of understanding for other specialties, maybe even gynecologists who don't do endometriosis surgery, maybe don't have that full understanding. And as someone who, lives, breathes endometriosis surgery day in, day out, you spoke in the early part of this conversation about excising this endometriosis tissue and cutting it away. What are the different sort of types of attack do you have when it comes to operating on endometriosis?
So I want to just point out you are a unique doctor in what you just described, right? But that should be the standard of care. And if
Mm,
every general surgeon and other surgical subspecialties approach the disease how you just described, we would help so many women, right? And so I really do think how you kind of sought out the endometriosis surgeries and kind of just hung out with those people to learn more, like that needs to be part of a general surgery training,
I think
right?
so.
Like these people could, that's probably the second most common place people land up. So that needs to be integrated into surgical training and residencies at least for a month, because then they at least know what the heck it is. They can explain it off the street, and they can, oh yeah, right. I did 1 month of endometriosis training with a endometriosis excision surgeon. Okay, yeah, it could be endo. Like, just to be able to say that to a patient is very powerful.
Absolutely. That's a really good idea, actually. That's a really good idea. I mean, there's a lot of useless rotations that I've done, which
Right.
I didn't enjoy. And gynecology would have been a very useful rotation because there's so much crossover
So much
between general
crossover.
surgery and gynecology.
And same thing with the ER. Like, we need those ER residents to come hang with us, because that's a huge touch point, right? That's
Yeah.
probably another huge place where people walk in. And again, ER docs, like I have friends that are excellent ER docs.
Yeah.
They literally, the only diagnosis you get to when you go to the ER with pelvic pain is an ovarian cyst. So
Mm.
if we can grab those residents even for 4 weeks, for 1 month when they're going through the ER, then at least they're gonna be like, "Oh, yeah, I spent a month doing that. I know what endometriosis is. This isn't an ovarian cyst." And then when they get out and train, they can literally jog their memory from those 4 horrible weeks they had to spend with a gynecologist or an excision surgeon and remember and just bring it up to the patient. That would be huge.
So, what would you typically do in excision surgery?
So it kind of depends on the extent of the disease, and this is evolving at the institution that I work for. For me, I'm really wanting to go in as best prepared as possible, okay? And so thankfully, the way I've trained surgically in the last 8 years, we've tried to do the surgeries without our colleagues in urology and out our colleagues in general surgery, right? And so the way that I function presently is that we need to be able to do, I mean, I think we've kind of been ingrained to be able to do what the general surgeon could do and the urologist could do. And I do think there's limitations there, especially with people that are up and coming. But ideally, what I like to do is kind of understand what are going to be like the worst case scenarios that I'm going to get into here. Okay. So understanding the involvement in bowel disease. So that's kind of the biggest thing is, do I need to have a general surgeon next to me
Mhm.
at the time so that we can properly take down this disease or take care of it? And then also, what about urological support? Because the ureter is a hot mess when it comes to endometriosis, right? And so we really need a strong urologist. I think some of the best in the country are also operating with a vascular surgeon. So, I mean, it's a that's the thing. It's like you have people like myself that are going in, like, we've seen these complications and you need to go in with the best. And thankfully, I have at my fingertips, like I can just call over to the OR and be like, I need so and so to come help me with this, right? But not everybody has that. And that also creates a huge burden on the system, right? Because you got these crazy extensive disease. So I try to walk into the OR knowing where my worst case scenario is going to be in terms from a surgical standpoint, and have those people alongside me to be able to support me in the operating room. Because again, I'm still learning and I'm still growing my skills. I think there's a strong push for certain types of excision surgeons to be able to do it all, be it all, know it all, cut it all out. And that's an impossible task. And I think we keep pushing people away from the endometriosis excision surgeries because there's a new level of standard of care. And then there's people that can can do it all. Like, it's crazy. Like, that just can't be. It has to be a group. Like, unless, we have some type of training for endometriosis excision surgeons where they can do all the things, but I just don't see that as realistic. You need to be able to go in with colleagues.
So the excision part literally means, cutting out the endometriosis that you see. And then you have also ablation where you burn the endometriosis. But it seems like, according to most studies, that there's higher rates of recurrence or the
Yeah.
endometriosis growing back with just ablation therapy, the heat therapy. Are they, use cases for both, or is excision always better in almost all cases?
You nailed it on the head. Excision is better in all cases. I think the hardest place is on the ovaries and kind of what to do on the ovaries, because you've got these lesions on the ovaries, and we're not talking about endometriomas. I'm not talking about these large collections of endometriomas. I'm talking about these like small ditzel lesions all over the ovary, just like studded all over, like freckles on the ovary. Okay, what do you do for those?
Yeah.
You're gonna scissor them out. You're gonna cold cut them out. Okay. If this person wants to get pregnant, you, you literally
Yeah.
just cut out a whole bunch of their eggs, lots of them. So what are you gonna
Yeah.
do? You're gonna excise those. Okay, you're not gonna do that. Now you're gonna burn them. Now you just burn their eggs. So you're gonna cut them, your eggs, or you're gonna burn them.
Yeah. Can't win.
I don't. I'm not sure. Like, I mean, we were in the OR yesterday, and they asked me to kind of come in and address this, and I was like, thankfully, this person was beyond fertility and was having surgery to remove their fertility, so I
Mhm.
could do some cutting and some burning without. But again, like, am I putting them into menopause?
Yeah.
Probably.
Yeah.
So again, like we're just I get in a really tough place on the ovaries, and there's probably someone out there who's done research to say that I'm, whatever, I'm doing it wrong and I should do it this way. But I get in a pickle every time with these like freckled ovaries, and the lesions need to go. Do you burn them? Do you cut them? And you're in a
Mm.
good space if the patient's near menopause, but that's not the majority of people.
How big an effect do you think endometriosis has on the average person who has it on their daily life? Because you've outlined how many organs it can affect and just how a single spot can cause this severe, horrible pain, but also that the surgery isn't necessarily an easy, quick fix either. So how big and wide ranging an effect can endometriosis have on a person, their employment, their relationships, and just their daily physical and mental health?
Yeah, it's significant. It's really significant. And that's again where I kind of go back to like, we can't fix this. Like we kind of have to go through and dissect how is this disease or how has pelvic pain affected your entire life? And how can we kind of work through some of that? So it's such a broad impact. I mean, I think people probably fall out of relationships because they have pain with sex and they can't have sex. And so then they're like, okay, well, that guy's not going to work out for me because I can't really meet his needs and I'm in all this freaking pain. Right. So there's like the relationship impact, or, their marriage ends because they can't get to a good place. Right. And then
Yeah.
they're not having sex and then the couple wants to get pregnant. Well, the woman can't even have sex because she has this disease. Okay. Well, we're getting a divorce. Like, and so it has a huge impact in terms of the relationship side. And again, then like that's one of the main questions I ask people is about like, can you go to work? Can you go to school? Can you go out with your friends? Can you do anything fun? No, I have to move my entire life around. I have to plan my vacations
Yeah.
around my kids' school schedule and my periods. Okay, so when are you going on vacation then between the period and the school breaks? Okay, I have like 2 weeks out of the year. Okay, that seems normal. So again, they plan their vacations. They have to choose different jobs, right? There's so many times I see people and I'm like, okay, I will fill out this paperwork for you. I'm just going to tell you, based on what you've told me, this job isn't going to work for you. This isn't the right job for you. These people are not supportive. And for whatever reason, they have their reasons based on what their employment structure is. But I tell them a lot of times, like, you need to look for another job. This
Wow.
disease requires the most attention in your life right now, and you need the most support from an employment standpoint, from friend standpoint, from relationship standpoint, from friendships. Like you need all of that support, and like you're just not getting it at your job. I'm sorry. Like and it's not going to happen. You need to change the job, leave the unsupportive spouse. Like it's so far impacting. And again, they just have also like all this like trauma too. So they've endured this years of like, I go to the doctor, there's nothing wrong with me. I go to see the general surgeon, they think I'm an idiot. Like they have all this like ping pong medical trauma. So even walking in the building is like, what's she gonna say? And at the same time, there's also a huge like trauma aspect from when it comes to like physical and sexual trauma that I mean, almost hate to say it, but like 75% of the patients that I see, I screen for this, right? And
Yeah.
and and they all have like physical, emotional, and I very rarely have somebody who doesn't have some type of trauma that they need to work through, right? And I think the hardest ones are going to be those physical and sexual traumas that people endure throughout their life. And I tell them all the time, like, we can do what we can, but the way that this has impacted your pelvic floor, and there's that great book out there, The Body Keeps the Score. I try to get everybody to read
Mm.
it or listen to it, right? Like you have to understand how all this trauma has impacted your body. And no matter if I surgically fix it, like your body hasn't forgotten the trauma, and the pelvis, right, holds everything. And so you have to work through that, because if I just cut the disease out,
Yeah, that's not addressing the mental, physical, emotional side of it. And what you've just outlined there is really that brain stress component and some of those lifestyle factors. I recently came across a review, which was one of the very few reviews out there which aggregated the limited data and research we have on dietary and nutritional manipulation when it comes to endometriosis. And again, I don't think you can categorize every single endometriosis sufferer as one condition, right? They're so different in the constellation of symptoms and their disease process that something which works for one may not work for 20 other people, and vice versa. But in this review article, they suggested that in a cohort of patients, a low FODMAP diet where they cut out certain types of fibers and carbohydrates had some effect on improving pain and symptoms. Now, that may be because a lot of people with endometriosis have GI symptoms because they also have other GI conditions like irritable bowel syndrome or other gut problems. So it may address the gut problem, not the endometriosis, and you get this overall improved symptom. Also, things like I think zinc and magnesium seem to help. But again, that may be because they were deficient in those and coming to a normal level may be improved. How big a role do you think diet and nutrition plays? And also when it comes to supplements, is there anything that you've seen in your clinical practice that you'd either recommend patients screen for or supplement with to have any chance of maybe improving pelvic pain or any other symptoms of endo?
Yeah. So for the diet stuff, I have so much to tell people when I see them for their consult, and I kind of feel
Mm,
like I gloss over the diet super fast, but I'm like, okay, you need to look at this section and you need to really find a book and someone who knows what they're talking about. But the basics is anti-inflammatory, right? Your body is processing so much inflammation with endometriosis. You cannot put more inflammation into your body.
mm,
You just can't. Like this is like a cutoff point, right? There's only so much inflammation that your body can process. And so we need to try to cut down what's within our control, right? We need to kind of cut out the inflammation that's within our control. And you can do that with your diet. But again, people aren't feeling well. So that's kind of the struggle I get into with the diet stuff with my patients is, okay, you don't feel good. So when I'm not feeling good, like I'm like going to Chick-fil-A, I'm going to, In-N-Out Burger, like I'm not okay,
yeah,
let's go to the grocery
yeah,
store and pick out this anti-inflammatory recipe and cook it.
yeah.
No, like you're it's hard cuz you're eating like crap cuz you don't feel good.
Mm,
And so I find that all the time I get into these kind of pickles, and I try to give people as much support as possible. Okay, look at this book. Can you outsource some of your food? Can you outsource some of your meal prep? Can you subscribe to something that like you don't have to rely on grocery shopping, cooking to get the proper diet stuff that you need instead of going to McDonald's for an entire week? So I try to get them to, and that's the thing, do they have the money to do that? Right? And a lot of these are young women. Like they don't have time to cook. They
yeah.
wanna go out with their friends. They're in college. What college person is cooking?
I found it really interesting that the NHANES data, for anyone listening who doesn't know what NHANES data is, it's obviously that sort of epidemiological data, where you got masses and masses of patients from a population and you're looking for associations between things. And it looked like an increased fiber consumption was associated with reduced endometriosis symptoms. And that was quite a clear association. And again, you can't draw a causative link between the two, but it seemed pretty, obvious that the more fiber you had, it's likely that your overall diet was probably more nutritious. I can't
Mhm.
really point to any examples of people who have loads of fiber in their diet and they eat just ultra processed food. It probably have a pretty decent, well-rounded diet full of antioxidants and
Mhm.
plant-rich foods, which we know it's the boring, non-sexy stuff, which usually does the stuff. And probably, maybe we could argue that that influences the microbiome some way and
Correct.
has some effect on endometriosis, without saying specifically how or why.
Yeah. Can you come to clinic and repeat that for my patients? I would love that. Just a little that little nugget. I do. I think, just doing what you can to optimize your gut health and not put crap into it the best that you possibly can. the microbiome and your gut will thank you. And I have celiac disease, but it was diagnosed very late in my life when I came in with a small bowel intussusception
Oh,
at a surgical conference. That was fun. But I had to completely overhaul, right? This is celiac disease is a disease where you don't really need meds. You literally just need to overhaul your whole your whole intake.
yeah.
That I'm not saying that was easy, and it took years for me to kind of do that work. But the impact that that had, I didn't even realize how the celiac was affecting my whole body, right? And that's a kind of an extreme example of optimizing gut health and how that can affect your whole health. The alcohol, that can play a big role, especially when it comes to bladder health. I also try to get people to optimize their bladder health, but there's only so much stuff you can cut out, right? So specifically with bladder symptoms, I'm trying to look to get people just drink this much water, get the graduated water bottle and start with like one of those and just follow the time breakdown. Same thing with acidic things, just the really acidic foods for your bladder health. Just get curious about it. Just write down, what you're eating, make yourself a little like map and see how your pelvic pain and your other symptoms respond to just kind of like certain types of foods. And so it just requires a level of curiosity from people and their willingness to want to try. As far as the supplements, I don't want to throw a lot of supplements at people and them spending a ton of money on supplements. Because again, a lot of times these patients are already taking numerous other pills, and
Yeah.
so I always find that that's where, like, even personally, where I fall off the map is like, okay, I have to take these pills or I'm going to be crazy. And so then when it comes to supplements, like your supplement runs out and you're like, okay, I'll just like wait like a couple months to get a refill on that. Or like, I don't really want to spend $60 on this crazy supplement. So
Yeah.
I try to focus on basically three things, and that's going to be magnesium, fish oil, and turmeric.
Mm.
And if someone's trying to get pregnant, I will say CoQ10, and a prenatal vitamin. But again, I kind of limit it there. Like just start with magnesium, turmeric, fish oil. Okay, you want to start with one, magnesium. Okay, you can't. Okay, we got the magnesium on board. You're taking it. You're actually picking up your magnesium. You've got it on, subscribe and save on Amazon. Okay, well, let's try to see if we can introduce the turmeric and then the fish oil.
And there was actually to really double down on your point, there was a very recent study published. I think it was this month in JAMA, and they were also looking at supplements and how it manipulates endometriosis pain symptoms. And two of the things they found that had the greatest association with pain reduction was peppermint and magnesium.
Hmm.
And this was, I think, done in over 2,000 people with endometriosis. And almost 50% of respondents to that suggested that, in their sort of group, peppermint and magnesium was up there in terms of how it, influenced their pain. So, and, you could also argue this is not going to work for everyone, but they're relatively low cost, non invasive, low
Hmm.
side effect profile things to try, considering
Hmm.
that peppermint, we know, is an antispasmodic and may help
Hmm.
from the sort of cramp spasm from the GI point of view. Magnesium, pretty well studied. It's a cofactor in so many things. A lot of people's diets aren't the best in terms of hitting the RDA and magnesium. So again, in terms of helping with the sort of muscle relaxation and blood
Hmm.
flow, maybe a useful adjunct as well.
Yeah, I haven't seen that one, but I'll take a look at it when we hang up. But yeah, I mean, those are just very small things you can do, right? Take a magnesium supplement and drink some peppermint tea at night. Ginger powder was another one that got a lot of press a couple years ago, and it was actually really implicated in during menstrual bleeding. And so this one was a kind of a tough one for me to sell to people on the ginger because I don't want
Yeah,
them to have their period if they have endometriosis. So I'm like, I don't know,
yeah.
don't buy the ginger because I don't really want you to bleed. But you know, for people who can't kind of go down that route, I guess ginger powder can help there too. But yes, these are small things that can make a pretty significant impact for some.
I thought endometriosis was bad enough, but people with endometriosis seem to just have it piled on because I can't remember when it was, but there was a Nature study looking at the genetic factors associated with
Mm.
endometriosis. And it looked that there were 42 regions of the human genome strongly associated with not just endometriosis, but other chronic conditions like asthma, migraines, osteoarthritis. And it looks like a lot of these chronic disease processes share overlapping biological pathways, which is why you see people with endometriosis often have one or more other chronic conditions as
Mm.
well. And I guess the more we can nail down that genetic cause, we
Mhm.
may begin to find adequate treatments for that.
Yeah, I'll be dead when that happens. I'll be in heaven just being like, "Oh, yes," if I make it there. But, again, one of the struggles I see is the fix it mentality where I have endo, I want you to cut it out and fix it, and I'm like, "We gotta look at all this. We gotta look at everything." And maybe you don't have time to look at your first visit, but we do need to look at that. And I think you're 100% right with the research and narrowing it down from a genetic perspective, we'll be able to kinda say, here's how we can help you best. Here's kind of the baseline underlying thing that's kind of causing everything else to explode. And it's widely varied. I mean, there's a few themes that I see out there when it comes to endometriosis and those chronic overlapping pain conditions. But again, I oftentimes think to myself, does this person just have like some underlying genetic thing that's
Mm.
predisposing this to all of it?
So, if a patient is going and seeing a doctor, they've had these various chronic problems. We haven't specifically labeled them, but they've got problems. They've been doing some Googling. They think it could be endometriosis as one of the things they've done. They're going and seeing a doctor. How can they best advocate for themselves? Or even if it's a friend or a family member going with that person, what are some things that they can do when they see a doctor to advocate for themselves so they're not fobbed off, brushed off, and really take their case forwards and also knowing their rights so they can, get like strong opinions, second opinions if needed, and yeah, really just come to the table with facts, data, and enough security so, they are going to be taken seriously.
Yes. So, and I actually saw this flyer this weekend about how to advocate for yourself in 2 minutes, and when you flipped it over, it had, like, basically a way to prepare your speech to the
Mm,
doctor, and it's crazy. People have to have a flyer
I know.
with this, like I mean, I looked at it, I was like, "If I had to go to the doctor and give you how to tell you I have endometriosis in 2 minutes and answer all of these questions in 2 minutes? No, that's crazy." Like, what? So I think what I tell people is I use a form, International Pelvic Pain, IPPS. They have a form. You could probably just print it off yourself
You could do
and
that at home, the IPPS
yes, there's an
scoring.
IPPS. Yeah, so it says IPPS. It's a pelvic pain survey, intake survey. You can get it from their website, although I think they restricted it a couple years ago, but you can probably find one out there.
Mhm.
And you fill it out, and it's gonna ask you to go through, like, all things that be causing pelvic pain, and it goes through such a wide variety, and everyone I see fills this out, and unless they won't fill it out, but it allows you to kind of think of your pelvic pain from a broader perspective, and you could just bring that and say, "Hey, listen, I filled out this well." I mean, this
Wow.
survey is used by a lot of really good pelvic pain and endometriosis people, and say, "Here, can you look at this? Like, maybe not while we're sitting here and talking, but can you take this and look at this? Or can we schedule a follow-up appointment? Can we schedule a 20-minute phone visit where we can sit down and go through what I'm telling you here?" So that's one idea. I also, like you said, encourage them to bring someone with them because a lot of times the patients will start talking and then you need someone else that can jump in and be like, "No, listen, she can't go to school." Like, she's
Mm.
right? Because the patients don't always
Speak
say
up for
how
themselves
much it
sometimes. Yeah,
impacts their life. They're like, "I have painful
yeah,
periods, and I have headaches," and, you know what I mean? All the things, like, "I just wanna get help," and then, like, the spouse or the friend or the partner will
yeah.
jump in and be like, "Listen, this is
Like, she's
ruining her life. It's
crying on
ruining
the
our
floor.
life."
Yeah,
Yes, yeah, and so when you have that person to, like, provide a broader perspective and be like, "She can't take care of our two-year-old. We wanna have another kid. What the heck is going on here?" That to me is a really powerful statement. A lot of patients are very well educated, and actually I kinda love that because they do bring things to the table and I learn from them too. And I try to ask this one very specific question after I listen to the story. And for me, it's when you leave this room today, when you leave this exam room, what's the one thing you need from me to feel like this was a successful visit? Okay. And a lot of times they'll tell you exactly what they need, right? I need you to cut my toenails. Okay. I'm happy to cut your toenails if that's what you need. I never know what someone's going to say, right? I've heard all kinds of things. But for a lot of them, it's like, I need you to tell me if I have endometriosis or not.
mm,
Right. And I'm like, okay, great. I listened to your story. I did your exam. I looked at your imaging. You have endometriosis. Have a nice day. And then for
wow.
some people say, well, okay, I have endometriosis and I want to have the surgery. Okay, great. Sounds like you have endo. Let's do the surgery. Or you could just straight up tell your doctor, I have endometriosis and then see what
And
they
she's like,
say.
wow,
And
okay, yeah.
if the doctor's like, well, I don't think you have it, be like, okay, well, I think I have it. So I need someone. Do you know anyone out there who knows anything about endometriosis that's in your network? Because I need to talk to them.
I think it's really refreshing hearing this perspective from someone who's so deeply invested and seeing endometriosis on a daily basis because, I think a lot of patients, certainly from the UK side and from what I see online in different countries as well, really struggle to get that diagnosis. And the stats don't lie as well, saying that people are getting on average 7 to 10 years of wait time before they get a endo diagnosis. So actually from hearing that from an expert like yourself, is actually really refreshing. And I hope, patients can learn from this and take that in their next sort of appointment to advocate for themselves.
Yeah. And I mean, you can, that's the kind of thing, personally, I have a kid with really severe ADHD, and I
Mm.
was put off for a long time, like, oh no, he's just a boy. And he's just like, and I'm like, finally, I literally was like, he has ADHD. You going to help me or not? Because I'll just go see the next person. Right. But I'm very bold, right? Like my husband had this horrible, during COVID, my husband got C. diff, right? But he didn't know he had C. diff, right? He went through like a month and they tried to kill him. And the whole time, I literally at one point during COVID, you weren't allowed to go into the ER I wasn't allowed to be in the room. And I said, I'm going back there and I'm literally going to write on the whiteboard exactly what he has. I wrote on the ER whiteboard, I wrote, he has C. diff. When he walked out of there, he said, the doctor said I don't have C. diff. Did they do a stool sample? No. Did they do any evaluation for C. diff? No, they gave me antibiotics. Then he became septic and almost died.
Wow.
So I get it. Like, I get it. Like, you could literally walk into the exam room and write on the board, I have endometriosis. Can you help me or not? Like, I think it's hard. And it's really tough. It's just so strange that you have to literally walk in and be like, my husband has C. diff and he's dying and he's septic. Well, he might not be. Well, he is. Okay. So don't run a pregnancy test on him. He has C. diff and try to kill him. He's not pregnant. So, I mean, you have to have this type of person like my crazy self
Yeah. Just to
in your
push it.
corner to be like, nope, that's what it is. Sorry. I even have patients, it's crazy. They finally get someone to believe they have endometriosis. Okay, let's do the scope. Okay, this person doesn't do a lot of endometriosis. They go in, they don't know what they're looking for, right? And I think we miss we have to educate our OBGYNs that this is all the different ways the disease can look. Cause I operate with people every single day and I'll say that's endo. Like, I don't think it is. I'm not sure if it is. I'm like, well, you just made it into endo by that statement. Okay. But and again, I take it out, I pull it out and I sometimes send it to them and be like, remember when you said that wasn't endo? It's endo. I'm like, these are smart doctors.
Yeah.
Okay. They just, and I have a video out there about the endometriosis rainbow, and I really need to trademark this quickly, but it's just a very basic rainbow that says these are all the different ways that endometriosis can look. We can present this to a med student as it's a cute little rainbow. And also the patients can understand the rainbow really easily. And the OBGYNs can understand this rainbow very easily. And you need to look for the red, the white, the blue, the clear, the yellow,
Mm.
the brown. Just look for the colors. But you need to be super close with your
Yeah.
scope, looking for all the different
Wow.
colors and the presentations. And if you at all think for a microsecond that could be endometriosis, it's probably endo. And I was going to say, I have these patients that'll come to me. They have someone that believe them. They go in there, they have the surgery. The person doesn't know all the different variable appearances of the disease. They take these faraway photos. There's no biopsies. There's
Mm-hmm.
none at all.
Oh,
Then
it's pointless. Yeah.
or maybe there is a biopsy. Okay, so maybe there is a biopsy, but let's just say they go in there, they're like, I didn't see any endometriosis and it's not there. Then they come to see me. They're like, well, I thought I had endometriosis, but I had a doctor believe me, and then I had the surgery and they didn't find anything. And I'm like, okay, did they take any samples? No, they didn't take any samples. It just told me I didn't have endometriosis. I'm like, well, that was a waste. That was a waste. I still think you have endo, right? Or my favorite is I had the surgery, I had the biopsies. They took these like little teensy tiny like ditzels, right? You need like 2 by 2 centimeter samples. You need big chunks of the peritoneum. I had these biopsies. The biopsies were negative for endometriosis. Okay, let me see what they look like. Let me see the size of these. Okay, they're like zero 0.3 centimeters by 0.2 centimeters, and it's cauterized around the edge. And the pathologist will say, there's no endo. I'm like, of course not. So
Yeah.
again, like these
Too
people
small.
already have been told and they've gone through the surgery and they've had the biopsies and like they're like and then you're asking them to go into an office and be like, tell them I have endometriosis, and And the OBGYN's like, well, you had the surgery. You had the
Yeah.
biopsies.
Yeah.
It wasn't there. I'm like, but this is all not adequate. And then we have pathologists on the other end. Like, let's just say you get a good sample and it's endo. Like some pathologists don't even know what they're looking for. Right. So I
Yeah.
even stopped I started to tell the pathologist what it is. I'm like, left pelvic sidewall with endometriosis. Right. I don't even like write the whole thing
And
out.
give them
Tell
an
them.
option. Yeah.
Yeah. I don't give them a lot of options. And they're like, she's crazy.
I think I don't think we can do justice to endometriosis in an hour-long podcast, but hopefully we've added something to the conversation out there so people can know more about this. And certainly, I think a lot of your tips to advocate are going to be overwhelmingly probably used and very useful as well. And I think we need to bring you on definitely for a round two because there's so much more we can talk about. Jill, thank you so much.
You're welcome. I would love that.